We are fortunate to have our honorable judges, two judges, Professor Dr. Michael Vanish from the University of South Australia and Associate Professor Dr. Nagib Sela from University of Malaya. I'm Chita from Jeffrey Chao School of Medicine and Health Sciences, Monash University. So we have 4 presenters this morning. The first presenter is MOHAMAD Zulfiqah Sadikan from University Technology Mara.
Hello, everyone.
Okay, so his research title is Effect of Palm Oil-derived tocotrienol fraction on the angiogenesis-related gene expression in the streptozotocin-induced diabetic retinopathy in rats. Once ready, you can start playing.
Vendor shares sound and restart.
Can we restart
And
the video?
Assalamualaikum warahmatullahi wabarakatuh and very good day to everyone. I am Zul presenting the effect of palm oil derived tocotrienol rich fraction on angiogenesis-related gene expression in streptozotocin-induced diabetic retinopathy in rats. I bet everybody knows about diabetes. This pathologic condition has been up to 422 million adults that have diabetes. This phenomena is characterized when there is very low insulin amount or very low sensitivity toward insulin, which correspond to type 1 and type 2 respectively. There can be a lot of consequences or complications as a result of diabetes, especially in cardiovascular, neurologic, and urinary system. But diabetes can also provide major impact in the eye by diabetic retinopathy or DR, which is the commonest microvascular complication of DM. So in global, 35% of diabetic patients develop DR and 10% has vision-threatening problem. This epidemiology is the same as in Malaysia. It is expected to increase from time to time. In general, there are biochemical and metabolic abnormalities that happens in the eye, which include oxidative stress, inflammation, apoptosis, and angiogenesis. So, for this presentation, I'm going to focus on angiogenesis. From this event, it can result in impaired vision and even blindness. From the hyperglycemic condition in diabetes, it can trigger polyol pathway, advanced glycation end product or AGE pathway, and protein kinase C pathway. And this can further cause oxidative stress, which is the imbalance between pro and antioxidant. From the oxidative stress, it will produce VEGF, and this VEGF cause ischemia and hypoxia. This phenomena will trigger more activation of VEGF responses, and with the help of IGF-1, it will produce excess of angiogenesis and non-competent vessel that further develop or contribute to the diabetic retinopathy. This is the structure of normal versus diabetic retina. The current treatment focuses on laser coagulation, anti-VEGF, and vitrectomy. However, they are invasive given at later stage and they have suboptimal outcome. Thus, we have proposed to use other medical alternative for this issue. We have proposed to use tocotrienol rich fraction which contribute to 75 of tocotrienol and 25 tocopherol. This structure of tocotrienol has the phenolic group which is able to combat against oxidative stress. The tocotrienol, which contribute to the most of TRF proportion, has superior antioxidant compared to tocopherol, and it has been proven to provide anti-angiogenic property in previous studies. Moving on to the methodology, by using oral route of TRF administration, I divide into three groups of rat, which are N, the control rat, DV, the diabetic rats, and DT, diabetic rat treated with TRF. And they were further assessed by fundus imaging, retinal angiogenic genes, and retinal angiogenic proteins. We proceed with the result. In this graph, normal rat showed a constant increase in every weeks of treatment period, but diabetic showed slow weight gain. Interestingly, TRF revealed a significant increment of weight gain from week 9 until week 12, which could be due to improvement on body metabolic activities. For blood glucose, normal rats maintain around 7 to 9 millimole of glucose, whereby DV rats indicate a constantly high blood glucose throughout the period. In DT, RBG reveal a lowering of blood glucose as early as week 4, which could be due to improvement on the uptake of glucose by the body cell, and maybe that is why there is improvement in body weight gain as well by preservation of body metabolism. For the fundus image assessment, we do adjustment first for brightness and contrast, followed by image calibration and selection of the zone near to the optical disc margin, and finally we do the assessment of the diameter. Moving on to the vessel diameter, retinal venous diameter was increased in N, DV, and DT at week 6 and 12, significantly compared to the week 0. Larger retinal venous diameter was observed in DV compared to N at week 6 and 12 significantly. However, smaller retinal venous diameter was observed in DT compared to DV at week 6 and 12. Whereas for retinal arteries, larger diameter was seen in DV and DT at week 6 and 12 compared to corresponding baseline. There were no intergroup differences for the arterial diameter at any point. For the effect of TRF on retinal VEGF protein and gene expression, firstly, for the protein quantification, the VEGF in DT group has been lowered as compared to the DV. This is in line with the gene expression, which showed lowering of angiogenic expression by TRF. This is parallel with the IGF-1 finding, which showed again lowering of angiogenic expression as shown by oral TRF treatment. Next is the discussion. The result that we have seen in blood glucose level is also revealed in previous studies, and TRF that reduces retinal VEGF and IGF-1 is believed to involve in MAPK and AKT signaling, and also associated with oxidative stress. TRF as a potent antioxidant may act by reducing oxidative damage and hence reducing VEGF and IGF-1. And interestingly, the VEGF and IGF-1 genes and protein expression are coherent with the venous diameter. In conclusion, this data provide fundamental knowledge of TRF against angiogenesis that beneficial for future. This is my publication, certificates, photos, and acknowledgement, the supervisors, the grants, and this research institute, and references. Thank you so much.
Thank you very much, Mr. Mohammad Zulfiqah Sadikan. May I invite Professor Michael to have some questions?
Thank you for your interesting presentation. I enjoyed it a lot. It's an important topic. I was wondering whether you had any results or measurements of TRF in the retina, and whether you had some more detail about where exactly it locates.
Sorry, Prof. In terms of assessment of what?
Of TRF in the retina?
Is that the morphology, Prof?
Well, I'm talking about the antioxidant that you've used, yeah?
Yeah, our current investigation is actually in retinal tissue of diabetic retinopathy rats, Prof. So we investigate the VEGF and IGF diameter.
Right.
Sorry, Prof. You were asking about the oxidative stress assessment?
Yeah, that's right. Whether it was done in the retina and whether you have measured the antioxidant in the retina.
Yeah, we have investigate on the retinal oxidative stress by measuring the glutathione catalase, superoxide dismutase, and malondialdehyde. But it is not included in this study as the study is still ongoing, Prof. So
okay,
we will reveal that later, Prof. Probably.
Will you be measuring the antioxidant, the tocotrienol in the retina?
For the tocotrienol part is actually commercially available. So we take note on the each of the component or content in the TRF itself. So we have the details. So we are not measuring that. So we're focusing on actually oxidative stress, angiogenesis, and currently apoptosis, and also inflammation. So we cover all this as the important part in diabetic retinopathy development and progression, Prof.
Okay, thank you for your answers.
I think, Professor Chair, I think you are muted.
Thank you very much, Professor Michael and Mr. Zulfiqah, for your presentations. Thank you. We will move on to the next presentation. Next presenter is Ms. Nuru Hayati from University Putra, Malaysia. Her research title is Salivary Protein Proteomic Identification is associated with subsequent allergic diseases in childhood. Okay, we shall start the recording first.
Very good day to all. My name is Nuru Hayati ZAINAL from UPM Sedang, and today I'm going to present in the MSPP 34 scientific meeting on my work entitled Salivary Protein Proteomic Identification is associated with subsequent allergic diseases in childhood. This is my presentation outline. Allergic diseases can be defined as hypersensitivity disorder of the immune system involving an IgA-mediated inflammatory event initiated in response to common environmental antigens, which include pollens, dust, and different food types. They occur when human immune system react to normally harmless antigen in the environment. Allergic diseases include asthma, eczema, allergic rhinitis, food allergies, and anaphylaxis. Allergic epidemic proportion has increased worldwide, whereby 300 million people have asthma, and they surely have negative impact on social economic welfare of the society. In Australia, a dramatic increase seen in anaphylaxis in children aged 0 to 4 years old. Hospital admission for anaphylaxis increased fourfold in the last 20 years. Food-induced anaphylaxis has doubled in the last 10 years, whereby 25% of infants now have an immediate food allergy. 19.6% of Australian population suffer from at least one allergy, and this number expected to increase to 30% of adult population by the year 2050. Allergic diseases are the most common non-communicable diseases in children and adolescents. They are significant health burden, thus preventative measures to reduce this burden are urgently required. We believe that prenatal events play a critical role in determining disease susceptibility via environmental influences on placental function and fetal programming. Our hypothesis is that childhood susceptibility to allergy is increased through significant alteration in placental function, and the product of identified genes are altered in the saliva of allergic children. Our aim is to identify salivary protein that could be a potential biomarker, to identify allergic risk in newborns, and to identify target protein for early allergy intervention. In our methodology, saliva sample were collected from 9 children with allergies that comprises of 3 from children with asthma, 3 children with eczema, and 3 children with rhinitis. And we have 9 control from children without allergy. The sample were then prepared via protein extraction using 2D cleanup and the protein estimation via EZQ quantification. Later on, the protein were treated with in-solution tri-tip digestion using 5 microgram of total protein and then underwent C18 cleanup to remove contaminant that might interfere with mass spectrometry analysis. Then the sample underwent liquid chromatography, tandem mass spectrometry analysis. But prior to that, we subjected the sample to metric assisted laser disruption ionization time of flight mass spectrometry, or also known as MALDI-TOF-MS, for quality control, whereby we try to make sure there's no polymer prior putting the sample in the orbi trap. Finally, we analyze the result using a software called MaxQuant to quantify the protein and a mascot software to identify the protein. Moving on to result and discussion, in the quantitative analysis of salivary sample, there were 177 proteins identified to be present in salivary sample of children with allergic diseases. Out of this number, 111 proteins had more than 2 unique peptide, or UP. UP is defined as a peptide, irrespective of its length, that only exists in one protein of a proteome of interest, despite this peptide may appear more than once in the same protein. Thus, protein that had more than 2 unique peptides had a higher probability of being a G9 protein and not a false positive result. From this number, 46 proteins were identified with a significant ratio when compared to the non-allergic group in salivary sample. This figure shows salivary protein in allergic phenotypes that have LFQ ratio of more than 2 or less 0.5 fold change as compared with non-allergic group using a max LFQ protein analysis. LFQ is level-free quantification intensity. Alright, as you can see here, the highest number of protein with more than 2-fold change were 12 in asthma group, and the highest number of protein with at least 0.5-fold chain were in the rhinitis group. This Venn diagram showing that there were 3 similar protein present in all of the asthma, rhinitis, and eczema group. This table shows some of the child salivary protein identification with significant LFQ ratio. This is a ratio of LFQ in children with asthma, children with eczema, and children with rhinitis. The top 4 protein here shows significant ratio of protein in all of the allergic children. The next 2 protein here shows significant ratio in asthma and eczema children. The next 3 show significant ratio in eczema and rhinitis children, and the remaining proteins here show significant ratio in only one type of allergic phenotype. 3 protein candidates were identified associated with subsequent allergic diseases in all children, which were human mucin 5B and 5AC, human serum albumin, and human serotransferrin. Proteins in both asthma and eczema phenotype only were cysteine-S and cysteine-1, and in rhinitis and eczema only were these 3 proteins. The current findings suggest that protein expression varies in since utero in children who subsequently develop allergy, and this altered expression are detectable in saliva in early life. This potential salivary protein can be used as possible biomarkers of allergic risk in early life and as potential therapeutic targets in allergic disease. This is the project workflow summary. After this, we are going to choose the protein of interest, and then we are going to validate the protein with Western blot and this system, and then the final interpretation of both saliva and placental result. I would like to acknowledge these very important people that enable me to do my research. I thank you.
Thank you very much, Ms. Nuru Hayati. And now I would like to invite Associate Professor Dr. Nagib Selak to ask some questions.
Okay, thank you so much for the presentation. Yeah, I'm not an expert in the allergy, but I just want to find out of all these proteins which you analyze, which one is the most promising you think that can be used as a biomarker in the future, and why do you think that?
Dr. Nagib, for the question. Can you hear me?
Yes.
All right. Okay. This research is actually consists of two parts, using a placental sample and saliva sample. So initially we conduct the same workflow with the placenta, and then after that we proceed with the saliva, because you are trying to find the protein that is present in both of the sample, to prove our hypothesis that changes that occur in placenta also occur in early life of childhood. So to answer your question, after doing the experiment on both of the sample, we proceed with actually 4 sample of protein that are present in the allergy children, and we validate the protein. And actually, because the protein is not really published yet, so I can't really reveal the name of the protein, but it's very promising. There's 4 candidate protein that are present in allergic children as compared to the children without allergies. Thank you.
Thank you very much. And we will proceed to the next third presenter, Ifrah Malik from University Technology Mara. The research title is Effects of Protoferl on Leptin-Induced Adverse Effects on the Male Reproductive System in Spring dolly rats. Okay, we can start now.
I am Dr. Ifrah Malik, a PhD student with the Faculty of Medicine, UITM. I am currently researching the effects of Profotil on leptin-induced adverse effects on the male reproductive system in Sprague-Dawley rats. Leptin is a cytokine hormone produced by the white adipose tissue. Though physiologically it has an important role in the male reproductive system, excess levels of leptin may have a detrimental effect. Studies conducted previously, including those in our lab, have shown that exogenous leptin administration in adult male Sprague-Dawley rats resulted in a decrease in the total sperm count, an increase in percentage of sperm with abnormal morphology, an increase in the levels of FSH and LH, derangement in histone to protamine ratio, increase in reactive oxygen species, increased sperm DNA fragmentation, and an increase in the levels of 8-hydroxyl-2-deoxyguanosine or 8-OH-DG. These increased levels of reactive oxygen species may lead to a state of oxidative stress, which in turn could have led to all these negative effects of leptin on the male reproductive system. This observation can be further strengthened by another study also conducted in our lab, in which melatonin, a potent antioxidant, was administered to leptin-induced rats. The results from that study showed that melatonin was able to prevent the leptin-induced adverse effects on sperm parameters. Our lab also showed the potential role of the PI3K signaling pathway in mediating the effects of leptin on the male reproductive system. As melatonin was able to mitigate the negative effects of excess leptin, it was decided that other antioxidants should also be researched with regards to their effects on the male reproductive system. Therefore, we decided to investigate this by treating leptin-induced rats with Profotil. Profotil is a vegetable origin capsule made up of several different antioxidants as shown in this table, and it is currently used as part of a treatment regime for the management of male infertility. Several studies have been conducted to observe the effects of Profotil in subfertile and infertile males. The results from those studies are shown in this table. To date, ours is the only study investigating the effects of Profotil in leptin-induced rats. So we know that increased levels of leptin lead to all these negative effects in the male reproductive system. Our aim was to administer Profotil and observe if it would decrease these effects of leptin. Our hypothesis was that since leptin induces oxidative stress, administration of Profotil would negate the effects of this oxidative stress, thereby leading to a reduction or prevention in the effects of leptin in the male reproductive system. To investigate this, our study design was as follows. Adult male Sprague-Dawley rats were divided into 4 groups. The first group was treated with normal saline. Group 2 was treated with leptin at 60 microgram per kg per day. Group 3 was treated with Profotil at 50 mg per kg per day with normal saline. And Group 4 was treated with Profotil and leptin. This dose of Profotil given was based on the clinical dose provided to male patients being treated with infertility. Treatment was given daily. Normal saline and leptin were given via the intraperitoneal route for 2 weeks, and Profotil was given initially as a pre-treatment for 1 week, followed by 2 weeks of treatment with either normal saline or leptin. It was given by oral gavage. At the end of the treatment, the rats were lightly anesthetized and then euthanized by cervical dislocation. The testes and cauda of the epididymides were collected, weighed, and used for further tests. These tests included measuring the total sperm count and fraction of sperm with abnormal morphology, measuring the levels of 8-OH-DG, measuring the total antioxidant capacity, and measuring the activity of the enzymes catalase and superoxide dismutase in the testicular tissue, and also investigating testicular cell apoptosis by tunnel assay. All data collected was analyzed by one-way ANOVA, followed by Tukey's post-hoc test. A value of p less than 0.05 was considered statistically significant. The results obtained were as follows. Total sperm count was observed to be significantly lower in the leptin-treated rats compared to control, Profotil, and Profotil plus leptin-treated rats. Percentage of sperm with abnormal morphology was observed to be significantly higher in the leptin-treated rats compared to control and Profotil-only treated rats. Though no significant difference was observed between leptin and Profotil plus leptin-treated rats, it was observed that Profotil administration into leptin-induced rats did cause the percentage of sperm with abnormal morphology to decrease. Therefore, administration of Profotil in leptin-induced rats prevented the decrease in total sperm count, as well as have a positive impact on sperm morphology. No significant difference was observed in the total antioxidant capacity between all the groups. However, levels of 8-OH-DG were observed to be significantly higher in the leptin-treated rats compared to control and Profotil plus leptin-treated rats. 8-OH-DG is a marker for oxidative stress-induced sperm DNA damage. High levels in leptin-induced rats indicate that these rats may be suffering from sperm DNA damage. Profotil administration in leptin-induced rats was able to alleviate the levels of 8-OH-DG. No significant difference was observed in the activity of SOD between all the groups. However, activity of catalase was observed to be significantly lower in the leptin-treated rats compared to control. Administration of Profotil in leptin-induced rats was observed to have caused the catalase activity to be slightly higher than that in the leptin-treated rats. However, no statistically significant difference was observed between the two groups. Tunnel assay indicated that the apoptotic index was significantly higher in the leptin and the Profotil and leptin-treated rats compared to control and Profotil-only treated rats. Profotil administration to leptin-induced rats was not able to decrease the testicular tissue apoptosis. So in conclusion, although given at a dose of 50 mg per kg per day for 3 weeks, Profotil was able to improve some of the sperm parameters in the male reproductive system. However, it was not able to completely prevent the adverse effects of leptin. It appears that treatment with Profotil appears to not be as active as preventing the leptin-induced changes as was previously seen in melatonin-treated rats. Perhaps a higher dose of Profotil or a longer duration of treatment may have brought about more significant results. These are my references. Thank you.
Thank you very much, Dr. Ifrah Malik, for the nice presentation. May I invite the Professor Michael for some questions?
Yeah, thank you for your presentation, Ifrah.
Thank you.
The question I had was, what do you think are the strengths and limitations of your study? Right, so we could focus on the strengths first in terms of their relevance to human, and then perhaps you could comment on on future studies, what you might improve over your current design?
So as strength, I would say that as we know that male infertility is a very big problem right now all over the world. And obesity happens to be one of the most common reasons for infertility. And leptin levels increase during obesity. And that might lead to all these negative effects leading to infertility. So we're trying to use the study to find out the mechanism through which leptin leads to this infertility and how we can treat it accordingly. So we might be able to help treatment of maybe provide a way to treat infertility in males. As for my drawbacks, I would say that since we saw from this study that this dose was not effective, so perhaps a longer duration of treatment or a higher dose of Profortil, or maybe looking at other antioxidants as well, either looking at them separately or in combination with each other might also help give a clearer picture of why, how oxidative stress is occurring and how it can be treated.
And now I was just wondering, I might have missed it from the beginning, but the rats that you were using, were they actually obese?
No, they were not obese.
What do you think the results might look like if you had used obese rats?
I think if I had used obese rats, I might have seen similar results, but because in this study we wanted to look specifically only at leptin, the effects of leptin, that's why we decided not to go with the obese rats, because obesity is a systemic disease, so it might have led to other adverse effects as well. So that's why we just chose leptin.
Okay, but in terms of translation to humans, at the end, you probably would, I would think you might need an obese model as well, yes, despite the confounding. So maybe for the future, do you think that might be something you do, or?
Yes, of course. Yes, thank you for the suggestion, Prof. Yes, I think, of course, because obesity as a whole should be studied. So for the future, we might be looking at obese rats themselves.
Okay,
thank you very much.
Thank you.
Thank you, Prof. Michael and Dr. Alfar. Now we will proceed with the last presentation, but not the least. Presenter is Parn Kim Wai from University Tunku Abdul Rahman, Malaysia. The research title is Subacute Orotoxicity Study of the Epigallocatechin 3 gallate in spontaneously hypertensive rats. So we can start the recording.
I'm Parn Kim Wai from Faculty of Medicine and Health Sciences, University Tunku Abdul Rahman. I'm presenting my research work on subacute orotoxicity study of epigallocatechin 3 gallate in spontaneously hypertensive rats. EGCG is the most abundant catechin present in the green tea and frequently being promoted as a cardioprotective agent due to its potent antihypertensive, anti-atherosclerosis, myocardial, and muscular protection effects. Nevertheless, many of the books are focusing on its efficacy and its safety profile has not been well established. Several case reports and epidemiological studies reported the GT-induced liver damage in long-term green tea extract consumers. In vivo studies have shown that GT treatment caused non-spastic lesions in various organs. However, the current evidence on GT-induced organ damage is not conclusive. Could the GT induce organ injury due to the EGCG that have been frequently promoted as a cardioprotective agent? In view of EGCG is the most abundant catechin and possesses the highest bioactive activities in GTE and its potential uses in treating cardiovascular diseases. This present study aims to investigate the safety profile of EGCG in HHR. A systemic review of 34 randomized controlled trials have concluded that high concentration of green tea and EGCG consumption lead to the elevated serum liver damage biomarkers. In addition, other than signs of hepatotoxicity, signs of cardiotoxicity and nephrotoxicity were also found in mice treated with EGCG. Thus, this study aims to examine the potential toxic effect of subacute oral ECCG in HHR. The objective of this study are to determine the effect of oral ECCG on food and water consumption, body weight gain, general behavior, sign of general toxicity, macroscopic changes of thoracic and abdominal organs, and its relative organ weight. This study hypothesized that the toxic effect of ECCG is dose-dependent, in which the higher dose of ECCG will cause a more severe toxic effect. The experiment was carried out according to the OECD Guideline 407, repeated dose 28-day oral toxicity study in rodents, with the animal ethic approval by Utah Scientific and Ethical Review Committees. EGCG with purity more than 94% was administered to HHR at a dose of 50, 250, 500, and 1000 mg per kg body weight through oral gavage for 38 days. Body weight changes, daily food and water consumption were recorded throughout the experiment period. Case site observation was conducted for 30 minutes daily. At the end of experiment, which is day 29, the animal was euthanized through excess inhalation of carbon dioxide. Thoracic and abdominal organs were observed for significant changes in size and external appearance. Case site observation was performed according to the following listed observations, which included the alertness of the rats, presence of eye secretion of inflammation, changes in movement and posture, sign of pyroreaction, changes in skin and fur condition, changes in appetite which assessed via food and water intake, changes in amount, color, texture of the stool and urine, and lastly, changes in the respiratory pattern. Macroscopic condition of the visceral organs in terms of size and weight, color, texture, sign of inflammation, presence of pus, ulceration, necrosis were recorded as well. Statistical analysis was performed using SPSS version 26. The numerical data was analyzed using one-way ANOVA followed by 2-key post-hoc. There were no changes in the weight gain except in HHR treated with 500 mg per kg body weight of ECCG show a lower weight gain at day 28. There were no changes in food and water intake in all the EGCG treated groups. 100% of the rats survived until the end of the experiment period. None of the EGCG treated rats show abnormal behaviors or clinical signs. There were no changes in the relative organ weight of the thoracic and abdominal organs. There were no changes in the growth anatomy of the thoracic and abdominal organ observed. In conclusion, oral administration of EGCG up to 1000 mg per kg per day for 28 days did not cause any significant toxic effect in the general health and growth morphology of the thoracic and abdominal organs in HHR. Nevertheless, serum organ damage biomarkers and histological changes, which serve as the gold standard in examining tissue or organ damage, should be performed to reconfirm the safety profile of EGCG. This study is supported by University Tunku Abdul Rahman Research Fund. These are the reference lists. This is all my presentation. Thank you.
Thank you very much, Mr. Kim. May I call Associate Professor Dr. Nagib Selar for any questions?
Thank you so much for your presentation. May I know why do you specifically choose spontaneous hypertensive rats, and do you expect any changes to the liver to occur?
The reason why we choose HHR is because this drug has shown to have a very good antihypertensive effect, but however the toxicity study have not done on HHR. So the first part of our study is to establish the toxic dose. Then after that, we will find out the highest dosage we don't have any toxic effect, and we will examine the therapeutic effect of this drug, which is the antihypertensive effect. So HHR is a very good model that demonstrates the primary hypertension to test for the antihypertensive drug.
So do you expect the EGCG will lower the blood pressure in SHR rats?
Yes, the ECCG actually has shown to decrease the blood pressure of the HHR. However, the decrease of, because when we use HHR, the very common normotensive control that we use is WKY. So when other study, which I share for the literature review, when they administered this drug to HHR, the blood pressure of HHR is decreased significantly, but still considered very high. Example, decrease from 180 to 160. So the decrease is not big enough or can reduce until the pre-hypertensive level. So we hypothesize that the dosage of ECCG is not high enough or the duration is short. So we will, in this study, we want to find out the toxic effect. We find out which the largest dose that don't have the toxic effect, and we will use the largest dose to demonstrate the antihypertensive effect. And we hope this antihypertensive effect will be large enough to reduce the blood pressure of the HHR even until to the normotensive level.
So basically, the effects of EGCG on those organs are indirect because it indirectly related to the reduction in blood pressure. Do you
Yes.
accept? Okay.
So actually, the toxicity effect of ECCG is more to the hepatotoxic effect, which cannot access to the observation of the organ or the general behavior. So in further study, so after that we will test for the serum liver biomarkers such as ALT and AST, and also do H&E staining of the liver.
So have they done the studies on the normal rats, the toxic effects of EGCG?
Yes, the study actually have been done on normal rat, but not in the compromised rat that have the disease such as HHR. They do the rat normally is using those normal rats such as the mule Swiss albino mice and also SD rat.
So they found the same dose have no toxic effects on the normal rats that you use. The same dose that you use. Other studies, what have they found? They found that they don't have the same toxic effects?
Actually, they found there is toxic effect in this dose, but the effect only can be shown using biomarker, which are the AST and ALT. So in next part of my study, we will also do AST and ALT to assess whether there is any toxic effect of the drug.
Okay, thank you.
Thank you very much, Professor Najib and Mr. Kim, for your presentation. So it's we have ended the section for the oral finalist 6, and before that, I would like to announce thank you for all the honorable judges, Professor Michael and Professor Nagib, and all the presenters for these presentations. And we will start the award ceremony and the closing ceremony with the photo section with all the attendees. So please rejoin back at the 11:30 for the link in the web for the closing ceremony. So now please turn on your cameras, and we will have a photo section for oral presentations. Thank you. Vanessa, yeah, you doing?
Yes, okay, everyone, please smile, yeah? In 3, 2, 1. Okay, thank you, everyone.
Thank you very much. Thank you once again, the panelists. Prof. Michael and Prof. Nagib and all the presenters for this section. Join back at 11:30. Thank you. Bye-bye.